So, hi everyone, thanks for joining me for this Facebook Live presentation on the biopsychosocial approaches to the treatment of male pelvic pain, including chronic pelvic pain syndrome, that's CPPS, and chronic non-bacterial prostatitis. My name is Karl Monahan. I am the owner of the Pelvic Pain Clinic. This is me, and I'm going to be with you for about the next hour or so, going through a range of applications to the biopsychosocial approach to the treatment of male pelvic pain. So I'm going to introduce myself very shortly and what to expect in the presentation. This is part one of part two presentation. The second part will be taking place next Thursday, that's the 14th of December at 11 a.m. The following Thursday, on the 21st, I'll be doing a presentation on hard flaccid. So I hope you're able to join us for at least one, if not both of those presentations as well. So, my name is Karl Monahan. As I said, I'm the owner of the Pelvic Pain Clinic, and I only treat at the Pelvic Pain Clinic male pelvic pain, and that includes chronic pelvic pain syndrome, chronic non-bacterial prostatitis, and hard flaccid as well. In today's presentation, I'm going to try and cover as much as I possibly can in terms of patient presentations. I'm aware I may not be able to get every single patient presentation, so I'm going to be trying to focus on the centre of the road here. I'm going to introduce a typical patient very shortly. We'll then start to look at the actual model of the biopsychosocial applications itself. We'll look at some research papers, tie it back all in together, and giving you a few thoughts to take away with you before next week's presentation. So, just some prostatitis facts. Remember that, so we're talking today about non-bacterial prostatitis, also known as chronic pelvic pain syndrome. So, a few quick facts around what you can expect. So I'm also very well aware that some of the patients today, some of the viewers today will be patients, some of them will be therapists, and there'll be people out there who probably have never come across pelvic pain before, certainly in males. So I'm going to give a brief introduction here. So male pelvic pain, prostatitis, affects roughly 16% of the males worldwide. It's the most common neurological diagnosis in men under 50 years old, and the third most common in men over 50, with prostate cancer and BPH being the most prevalent. Now, what you may notice from some of the facts and references for today is that some of them are quite old. And the reason being here is that back in the 90s, there was loads of research done on prostatitis and chronic pelvic pain syndrome. In the early 2000s, a little bit less, and actually in this decade, there's not very much at all. So a lot of the current research is actually based upon previous research. It's said to affect up to 50% of all men in their lifetime. That's 1 in 2 males in their lifetime. And typically, the presentations include pain, sexual dysfunction, and urinary issues as well. And now it's been likened to having an impact on life similar to people suffering with angina and Crohn's disease in terms of the distress and the difficulties in coping with the actual condition itself as well. So let's introduce you to a typical patient. Tony is more of an amalgamation of many of my patients that I've seen over the last 9 years or so. So he's not a real person. He's recently gotten married. He's 31 years old. He has a mortgage. He's looking to start a family with his wife. And he has had symptoms of chronic pelvic pain syndrome and prostatitis, chronic prostatitis, for the last 18 months. He originally went to the doctors with an ache in his testicles, occasional pain on ejaculation, and some burning on urination, although not every time. Now, he has seen 3 urologists. He's been back to his GP on countless occasions. The urologists he's seen have both been private and over here NHS. He's had a variety of diagnoses, including chronic prostatitis, overactive bladder syndrome, interstitial cystitis. He's been told there might be calcifications on his prostate, possibly from a previous infection. He's also been told he might have a twisted testicle and a varicocele as well. So some of these might be contributing to the sensitivity in the area. So over the last 18 months, his pain has really started to escalate. It started to morph an awful lot, and it shifts and moves around. He's now getting symptoms on ejaculation every single time. He now gets burning on urination every single time. He's got a rawness at the tip of his penis, a golf ball sensation in his perineum, and he's having a dull, dragging sensation in his testicles now, both of these. He's been told by the specialist that it's a difficult condition to treat, that this is something he's likely to have to live with for the rest of his life, that there's an infection buried deep within his prostate, that only the strongest antibiotics will be able to penetrate and get anywhere near this infection. He's had numerous blood tests, urine samples, semen tests, flow tests. He's been tested at the gum clinic for a whole range of things there. They have all come back negative every single time. He's had an ultrasound to his bladder, and he's had an MRI now as well. He's been given antibiotics, alpha blockers, antidepressants, and anti-inflammatories. He's now even been told he might have to go on some sleep medication as well. Having gone online to Dr. Google, where most patients end up going because they can't often find direct or the right answers from their healthcare specialist. So he's now taking things like saw palmetto, bee pollen, quercetin, lycopene. He's now stopping having things like spicy foods and alcohol, caffeine. So he's really starting to withdraw from life and actually the things that he takes pleasure from. Doesn't socialise anymore, and quite often when he gets back from work, he goes and lies down. So his relationship with his wife, he feels, is not going as well as he would like it to. As I said, they're looking at having a family and extending just himself and his wife. And he's worried about having sex with his wife now in case, because of the supposed infection deep within his prostate, he's now worried about infecting his wife and the knock-on effect that will have to his own future family as well. So, as you can see, things have really, really started to escalate. And this is quite typical for most of the patients I end up seeing. And there's a number of different factors here. So we look first of all at some of the physical factors that are happening for him, the physical changes, his escalation of symptoms, the fact they move around, the fact they've progressed and spread from the area where they started. He's now having mental battles in terms of what he should and shouldn't be doing. Should he be having sex with his wife? Should he be taking this medication? Should he be going on to Dr. Google? And socially, he's withdrawing as well. So not only is he not socialising anymore, in fact, what's happening in the family unit is also having a knock-on effect. His relationship with his wife. He doesn't go and do activities like he used to either. So actually the number of sports and just general hobbies he's doing has greatly reduced. So already there's a biological, a psychological and a sociological impact of this particular patient. So like I said, he's fairly typical. So this is a good time to introduce the biopsychosocial model. This isn't something I've come up with. I wish I was that intelligent. I really do. In fact, the model's been around since the late 70s, so for 40 years. Now, George Engel was the guy who originally came up with the model, and it was to challenge what was going on in terms of the biomedical presentation. And a biomedical presentation is almost like a reductionist model, if you like, where we focus on one sole contributing factor to, in this case, a syndrome, a collection of symptoms. And quite often, urologists and GPs will look at the prostate as being the primary cause for this collection of symptoms, hence the reason why it's called prostatitis. So a reductionist model looking at simply one contributing factor. This is a biomedical approach. And we've been taught this now for 400 odd years or so. And it's a Cartesian separatist model. It's something that doesn't take into account the whole patient. It primarily just looks at physical changes. And we've always been told that in order for us to experience pain, there has to be a physical change or physical damage. But actually now, in terms of our understanding with pain presentations, pain experiences, both chronic and acute, there's so many more factors that come into play here. So many more factors that can ramp up pain and conversely reduce a patient's symptoms as well. Now, ever since George Engel came up with his original biopsychosocial model back in the 70s, there's been a number of other versions that have modified, updated, added to, had different commentary. So Louis Gifford's mature organism model, Mick Thacker's revised version of this. We had Ron Melzak's body self neuromatrix, and more recently Lorimer Moseley and David Butler have brought to us Explain Pain and everything that comes along with that as well. So actually the biopsychosocial model isn't solely specific to chronic pelvic pain syndrome and chronic prostatitis. Actually, it can be applied to any health condition. And in fact, it can be applied to our general health. When these elements are in balance, so when our social aspects of our life are in balance, when our psychological aspects of our life are in balance, and when the physical aspects of our life are in balance, we generally have good health. But if they become a little bit unbalanced and one can have a knock-on effect onto the other, then we can often see symptom escalation. We can see symptom changing. So whether it is a broken leg, okay, we can apply the biopsychosocial model to a broken leg. We can apply it to, and this was one of the things that George Engel spoke actually back in the 70s in his paper, we can apply it to things like schizophrenia as well. So it's not solely related to chronic pelvic pain syndrome and chronic prostatitis, and that's key to remember as well. So we're going to start to look at a little bit of each of the domains in relation to chronic pelvic pain syndrome and CPPS. So this list isn't exhaustive. There's so many more things we could put on this. I just wanted to give you a bit of an example as to what you might expect to find in some of the presentations. So the biologicals, this is the physical changes we might expect to see in a patient presenting with chronic pelvic pain syndrome. So we might see muscular tension. This is often the very first thing we find or we're told of is the cause or certainly a massive contributing factor. I'll cover a research paper in a little while to reinforce this. We might see changes to a patient's breathing. They might become more shallow. We might see inflammation happening locally within the area where that patient's getting their symptoms. We might see changes to the sensory cortex up here. We might see changes to the motor cortex, which sits alongside it. We might see an increase to nerve sensitivity. Other things you might expect to change are changes to the endocrine system, so our hormones, maybe changes to testosterone, changes to digestion itself, like I said. So this list goes on and on and on and on. But quite often we end up using the reductionist model, focusing on one thing. For example, muscular tension. And what I want you to be aware of is that all of these other changes that happen in the body are perfectly normal and can be applied to many other health conditions as well. So someone with a stiff neck, for example, someone with ongoing neck pain, and I try and normalise chronic pelvic pain syndrome and prostatitis by referring to it to other conditions as often as possible to explain to my patients that actually what they're going through is really, really normal. So someone with neck pain, chronic ongoing neck pain, they're not likely to move their neck very well. They're likely to be stiff in their upper body. Maybe they get headaches. Maybe they get some back and shoulder tension. Maybe some TMJ involved in there as well. And they'll see changes to their breathing patterns. You might see inflammation happening within that area. There'll definitely be changes within the sensory cortex, the motor cortex, the limbic system, all those other parts of the brain that, again, I'm just not clever enough to be able to go into the detail today. So there's some of the biological changes we might expect to see in a patient suffering from chronic pelvic pain syndrome or chronic prostatitis. So what about some of the socio and or socioeconomic associations that might come along with this type of presentation as well? So we're likely to see changes to relationships. So the patient who's suffering with this sort of condition, syndrome, symptoms, we're likely to see changes in their relationships to people at work, their personal relationships, so whether that is their own family, their partner, maybe their cousins, maybe their uncles, maybe their aunts. What about friendships? You know, all of a sudden when we're having to deal with this, and I've had pelvic pain myself, I'm going to come and bring in some of my own examples from my own personal experience myself as well, that we don't feel ourselves. We often feel like we can't interact properly with the world and those closest and dearest to us as well. We might find that actually it's really socially unacceptable to talk about pelvic pain. And whereas neck pain, everyone has a story about neck pain. Everyone has a remedy. Everyone has a therapist they've been to. It's very well documented. It's heavily researched. It's socially acceptable. It's a sexy condition, if you like. Pelvic pain isn't sexy. If anything, it's the opposite of sexy because of the location where it happens. And in fact, it can often make a male feel very unsexy, very sexless. And again, I will cover this very shortly as well. Patient can feel isolated. Although the prevalence, certainly recorded data suggests it's roughly 16%, I'd argue that there are plenty of cases that go unreported. The patient can often feel isolated, that they don't feel they're able to talk about what's going on, that they often feel that people don't understand what they're going through. Because outwardly, they look fine, they look healthy, they look fit. Nothing's in a cast, they're not really changing outwardly, they're not changing massive amounts of their behaviour. There will be changes to their behaviour, but not so. Someone with neck pain, you might experience them walking around very stiffly, unable to move their neck. You might see someone moving stiffly in their pelvis and lower back if they have pelvic pain, but if you're not used to seeing that, then of course you won't be aware of it. The ability to work changes, and our confidence in our own ability to work changes. The number of sick days that are taken, the number of times we have to come up with excuses to our boss or to our work colleagues as well. And sometimes patients don't tell anyone that they've got this condition. I have patients who don't tell anyone at all. They're dealing with this by themselves. Work colleagues, their work partners, their own partners they live with sometimes don't know what's going on. So again, it is really, really quite isolatory. Again, much like what happens in terms of social interaction, they may be not feeling comfortable enough to go down to the gym perhaps, or play football, or whatever social activity they choose it might be. Bridge, playing cards, fishing, whatever that might be. So actually we see a change in the amount of activity and exercise that a patient ends up feeling confident in their ability to be able to go and do. And quite often the worry and concern is that, am I going to make myself worse by doing these activities? And because the information out there is so vague and so grey from the urologists and the GPs, then the patient often feels very uncertain about themselves. They don't feel robust enough, and they rely on the internet to give them answers. And I'm not sure that's the best place to find answers. So, some of the psychological factors that we might see include, and again, these are very common for any long-standing symptom, catastrophization, hypervigilance, that's the constant checking in of the area, being aware of any minute or small change, and what that then means to the individual as well. My symptoms are moving around, it must be something horrifically bad going on in that area. Patients often suffer with anxiety and are often given anti-anxiety drugs as well. Fear avoidance is the avoidance of doing activity in fear of making things worse, for example. Patients often feel stressed and worried and concerned with what's going on, really uncertain about themselves. So these are just a snippet of some of the things that patients with chronic pelvic pain syndrome, chronic prostatitis might be presenting with. Therapists, you might be aware of some of these. They might have been discussed with some of your patients. Patients, you may be very aware or not even aware of some of the other possibilities in terms of the socio and the psychological factors as well. So I just want to today to raise your awareness to other factors that are going on that are very normal. Okay, incredibly normal in patients with chronic pelvic pain syndrome and chronic prostatitis. And I would encourage those treating men with this particular condition to engage in conversation. Men suffering with this particular condition, I would encourage you to be more open and to talk about what's going on a little bit more. Females are great at this. On the whole, we don't tend to talk much, us men, and we don't tend to talk much about our health problems or our health conditions. I would argue that it's probably more socially acceptable to talk about neck pain than pain down there, and I think that has a big implication in this particular set of symptoms as well. So I want to draw now on some research that's out there. This isn't just my ramblings. I want to back everything I say up with research. So I'm looking at evidence-based medicine. I'm going to draw now on a number of different papers to make you realise that there are other things going on in the body than simply the physical presentations. So the first paper we're going to look at is about prostate tenderness. Now, this was from 2007, so again a decade ago. Not very much has been done, like I said, in the last 10 years or so, unfortunately. And this looked at tenderness in patients with pelvic pain prostatitis and those without. So there were 62 patients with type 3, that's chronic prostatitis, and there were 98 patients with no pelvic pain symptoms at all. And the reason I like this paper, there was one released actually the year afterwards in 2008, but the reason I like this paper in particular is because of the rigour that they went through in terms of researching this and presenting this as well. So what I mean by that is, when a study is rigorous, they tick all the boxes, they cover many aspects, everything is written in the paper so as the individual, we can read about this. And we know, for example, that there were 2 urologists and 1 nurse that were used to palpate and to press on these specific tender points around the internal pelvic floor and externally as well. And these 3 experts would recalibrate and check their pressure every single week. They trained for this particular study. So I like this. For me, this is really good. This is good evidence-based medicine. Now, what was really, really interesting is that you'd expect patients who don't have any pelvic pain to present with no tender points in and around the pelvic floor, internally or externally. And you'd expect patients who have pelvic pain to present with tenderness internally and tenderness externally. That's where we feel our symptoms when we have pelvic pain. So that would make sense, wouldn't it? But that wasn't the case. And prostatic tenderness, for example, was present in 75% of men with chronic pelvic pain syndrome, not everyone, and 50% of men who had no symptoms. So we get prostatic tenderness on palpation in patients that have no symptoms whatsoever. I find that really interesting. And we're going to apply a few more of these papers to this as well. And I find it really, really beneficial, because what it actually makes us realise is that we should stand up and pay attention that because a patient has physical symptoms, it doesn't mean that we're often going to be able to find physical changes. And that's my kind of one of my take-home messages from today. So the next paper we're going to look at is about bacteria and prostatitis, and how often the bacteria that's present doesn't correlate with a set of symptoms either. So this was a paper taken from 2002, again, early noughties, and this was a paper that assessed 488 men, and participants were classified as having type 3 inflammatory prostatitis. They did a 4-glass STAMI test. Now, for some of the patients out there, you might have come across this. The 4-glass STAMI test was deemed as being the gold standard in terms of identifying inflammatory markers within the prostate. It's really rarely used now, unfortunately. Therapists, you may have come across this particular test yourself. You may have, perhaps some of you, used the test in previous years. And all patients who entered this particular study had been off antimicrobials for at least 3 months and didn't have any urinary tract infections for 3 months either. And what was interesting is that there was no association between colonization in terms of bacteria and symptoms. So bacteria presentation within the prostate did not correlate to the patient's symptoms that they were experiencing. And I find that, again, very, very interesting, because you'd expect that if you've been told you've got an infection within the prostate, that actually you should have huge amounts of bacteria, or a level of bacteria anyway, and that bacteria would be very relative to the symptoms that we're experiencing. But actually, again, that's not the case. So we can have bacteria, we can have prostate tenderness in patients who don't suffer with this particular condition. So there's not a direct correlation as we might have originally seen. Now, we're looking solely at the moment at physical presentations. And my biggest issue with this is, regardless of the presentation, that men with chronic prostatitis routinely receive anti-inflammatory and antimicrobial therapy. And the observation of this particular paper, Schaefer 2002, was that inflammation and infection, as we defined them, do not correlate with the severity of symptoms that suggest other factors other than inflammation and infection also contribute to symptoms associated with chronic pelvic pain syndrome and chronic prostatitis. Not my words, these were Schaefer's, this was 15 years ago. For your reference, I'm going to write a blog and it's going to include all of the research papers on there, so you can go onto my website after this. You can click on the link on my website. It will take you through to the paper. Now, depending on your access levels to the papers, you'll be able to read either the abstract or the whole paper itself. I can't provide you, sadly, with the whole papers, but information is out there, and it suggests that actually inflammation, prostatic tenderness, bacterial infection within the prostate do not correlate to symptoms. I'm going to look at the next paper, is done by a chap called Schaefer, who's done in 2000 and, well, it's actually 3 papers. So we're going to look at type 4 prostatitis. Now, I'm not so, let me just make sure I'm bringing up the right paper. Here we go. So the NIH, the National Institute of Health, came up with a classification system for prostatitis. And type 1 is acute bacterial prostatitis, type 2 is chronic bacterial prostatitis, type 3 is chronic non-bacterial prostatitis, the type of patients that I treat, and again, depending on the statistics you read, effect is up to 98%, or certainly more than 90% of all cases of prostatitis are non-bacterial. But the one I find the most interesting, when I first started looking at prostatitis a decade ago, was type 4. So type 4 prostatitis is asymptomatic prostatitis. Now, that is, there's inflammation occurring within the prostate, but the patient has no symptoms whatsoever. And quite often, the reason that the way they come across this is actually through looking at patients with prostate cancer. Back in 2008, Schaefer was interested in documenting inflammation in the prostatic tissue or in the seminal fluid in prostate cancer patients. So that's once they've had a biopsy. So tissues from the prostate have been removed, they're assessed, they look for prostate cancer. And what was interesting is that the most common other feature that was often found was this inflammation within the prostate. But they're not getting the chronic pelvic pain syndrome symptoms. Interesting. So I'm going to show you, or I'm not going to show you, I'm going to describe 2 other papers. So one was by Carver back in 2003. This is where 300 men were randomly selected for a prostate cancer awareness screening program. And they were to be evaluated for type 4, that's asymptomatic prostatitis. And of the 300 men, 227 had expressed prostatic secretions collected, and they found that in 32% of these men, they presented with inflammation within their prostate glands. Asymptomatic, so no other symptoms. And again, this makes me really curious. What is going on within the prostate, and why isn't it necessarily correlated to the expected symptoms we would typically want to find, or expect to find, I should suggest, in this kind of presentation? So let's forward a little bit. Let's go to 2008 and Korovitz. And Korovitz was looking at the prevalence of asymptomatic inflammatory prostatitis in young men according to semen analysis. So this was nothing to do with prostate cancer this time. And the study consisted of 565 men, aged 19 years, give or take 2 years, and it was an examination of their ejaculates as analysis for basic semen parameters, and the clinical examination for possible pathologies in the genital region. Now, the prevalence of asymptomatic inflammatory prostatitis was 6%. But they changed the threshold in terms of they changed the data they were looking for, and this always happens. So when you change the data in a research paper, of course you can find more information. But they changed the threshold in terms of the number of inflammatory markers they were looking at, and all of a sudden the prevalence jumped up to 19%. So, according to this paper, it suggested that roughly 1 in 5 men of around 18, 19 years old have inflammation within their prostate glands but have no symptoms. Again, I find that really, really interesting. So the conclusion for this particular paper by Korovitz in 2008 was asymptomatic inflammatory prostatitis has a notable prevalence among young, healthy men, suggesting the need for further studies to investigate pathogenic mechanisms of the disease. So, like I said, we're not really seeing true correlations all the time. Why is this important? Now, I'm going to, again, like I said earlier on, I'm going to try and relate this back to other factors to try and normalise an awful lot of what's going on within and around the pelvis. So in 2015, and forgive my pronunciation of the particular author of this paper, I think it's Birinjikji and co. carried out a systematic review of 33 papers and 3,110 patients. And what they were looking for were pain or lack of pain presentations in degeneration within the spine. So these were MRIs taken of the spine, and what they found is that degeneration that occurred within the spine didn't correlate with patient symptoms. So these scans were done on patients who were asymptomatic. They had no back pain symptoms at all. And actually what they found was really, really key. They found key spinal degenerations, but the patients had no pain symptoms at all. Let me give you some examples. So 68% of 40-year-old patients had disc degeneration, but no pain. At 60 years old, this rose to 88%. So in this particular cohort of patients, this 3,000 plus cohort of patients, they found that 88% of 60-year-olds had disc degeneration but no pain. At 40 years old, 50% of patients had a disc bulge but no pain. So what this paper also covered was things like disc height loss, disc protrusion, facet degeneration, a whole range of other what we would call typical pain presentations within the spine. But actually the findings were these changes can happen, but the patient doesn't have the symptoms that would typically be associated, as we've always been told, with disc degeneration or a disc bulge or disc height loss or disc protrusion or facet degeneration. Why is this important? Well, it's the physical changes we see within the prostate, like the white blood cells, like the bacteria, that don't correlate to symptoms, or that symptoms have no correlation to the white blood cells, the inflammation, or the bacteria that's present within the prostate. Something else is driving this particular pain presentation. And this is why I come back to this biopsychosocial model, is there has to be other factors that are driving this. Other worries, other fears, other anxieties, other concerns, uncertainties. What does this actually mean? And also that by looking solely at the prostate, we're not taking into consideration the whole patient. And again, that's my big issue, is that neurology do a great job in terms of other conditions. It's just a shame that for chronic pelvic pain syndrome, chronic prostatitis, the patient feels let down. There's not enough evidence, there's not enough research out there at the moment, and the current practice is to just throw antibiotics at patients. 3 months, 6 months, follow-ups in 12 months. We'll try this, so we'll go and see this particular therapist, go and see this urologist. The patient feels let down, and that's really important to consider when we must take on board what this patient is going through. So let's carry on this thread. Let's look at some other research papers that are out there, and let's look at something that we would typically associate with a presentation of pelvic pain. So you might have heard of things like levator ani syndrome, proctalgia Fujax. We're often told that there's tightness in the pelvic floor in patients with chronic pelvic pain syndrome. Anderson and Wise, headache in the pelvis. I'm sure many of you as therapists and patients are very well aware of the book and their discussion on tightness and trigger points within the pelvic floor. And now if we can treat the trigger points, then we can get rid of the pelvic pain. I even made a video for TheraWand on these trigger points within the pelvic floor. And what I've realised is that over time, research changes, our understandings start to change. there's actually an awful lot of question as to over what a trigger point is, and even if they exist. But let's look at this paper first of all. So this was a paper that was written last year, and this paper covers the role of pelvic floor muscles in male sexual dysfunction and pelvic pain. And it's a fantastic paper. Again, there's the link on my website, so feel free to click on it. It will take you through to the paper itself. The paper looked at muscular tightness in association with erectile function and the pelvic floor. It looks at muscular tightness in terms of ejaculatory and orgasmic function and the pelvic floor. And it looked at the role of the pelvic floor in association with chronic prostatitis and chronic pelvic pain syndrome. And the findings were really, really reflective. That neuromuscular re-education, for example, has been shown to result in a reduced resting baseline tone of the pelvic floor muscles. So we're re-educating the pelvic floor muscles to relax, to drop, to soften. And we find successfully that this results in a resting baseline tone, so the tonicity of the pelvic floor muscles changes. Well, and the paper goes on to suggest that manual therapy to release painful myofascial trigger points in the pelvic floor, combined with paradoxical relaxation, this is the Anderson and Wise approach, involving relaxation of the pelvic floor muscles, has been shown to improve symptoms of pelvic pain, lower urinary tract symptoms, and sexual dysfunction in men. These are positive things. And the authors, so Cohen and Co. 2016, proposed that because muscle activity is a reflection of neural activity or neural control, and what I mean by that is that muscles don't tighten up by themselves. There has to be other processes in place in order for that to happen. Now, that might be behaviour modification, it might be a protection, it might be a reduction in movement. It might be simply that, as in the neck pain, the patient starts to really change the way they interact with the world, and therefore we see an increase in muscle stiffness. Makes sense, doesn't it? If you're in pain, what do we tend to do? We tend to protect that part of the body, no matter where it is. The pelvis is no different. But what Cohen suggested was that actually the muscle activity is a reflection of neural control, meaning that the nerves have to interact with the muscles in some which way, shape or form in order for them to tighten and stiffen up. So therefore, pelvic floor dysfunction associated with pelvic pain might indicate there is a primary or secondary central nervous system disturbance in regulation of these pelvic floor muscles. That's really, really key. Love this paper. As a massage therapist, that's my background stemming back 16 years. As a massage therapist, I like to find something that's stiff and tight, and I like to be able to work it out to alleviate that. But sometimes, unless we're addressing other things, that muscular tightness and stiffness isn't going to change very much. In fact, if anything, I would argue that muscular tightness and stiffness is almost an end product. That there are so many other cascading events that happen within the body before this can happen. And for it to remain switched on as well also takes a whole host of other events happening within the body for that to occur. Why is that important? Well, muscles are tangible. We can often feel muscular tightness or stiffness or resistance by pressing into them. And in terms of the pelvic floor presentation, this is the go-to place for treatment for chronic pelvic pain syndrome and chronic prostatitis. And I think as an integrated approach, it works really, really well. An integrated approach is the key thing here. There's nothing wrong with treating tight muscles. I do it myself. But let's consider everything else. Let's not use that reductionist model. Let's not just focus on the end product. Let's look at other factors that might be keeping that muscle hammock sling in the pelvic floor tight and switched on and active. So, the conclusion of this paper is that although treatment of the pelvic floor has been shown to result in significant functional improvement to sexual health, these aren't my words, these are from the Cohen paper 2016, improvement of sexual health in selected men with concomitant pelvic floor and sexual dysfunction, that pelvic floor rehabilitation is an important part of a more comprehensive, multidisciplinary, and I'm going to need to read this out now, bio-neuromusculoskeletal psychosocial model. So it's a big, big word. So the bio-neuromusculoskeletal, that's the physical presentation, the biological stuff, in terms of the nerves that are helping to switch the muscles on, in association with the psychological and sociological approach to the treatment of male pelvic pain, chronic pelvic pain syndrome and chronic prostatitis. That's really, really very key. Great paper, and I love the fact they address other issues in it as well. They draw in other factors that are contributing. So we've looked a little bit at the physical presentation of the pelvic floor muscles. We've looked at things like asymptomatic type 4 prostatitis. We have looked at bacteria infection and expressed, so white blood cells, inflammatory processes within the prostate itself as well. I now want to take a bit of a slightly different approach and draw on the psychological and sociological factors. And the reason I like this paper that I'm going to show you now is it's a systematic review. So what does that mean? Well, it means that someone else has done my work for me, that I don't have to go and research all the papers that are out there and come up with a summary as to what's happened. That this paper from 2014 by Regal et al., where's my French, actually, well, let's show you. So the paper looks at the psychological factors, social aspects and psychiatric comorbidity associated with CPPS and CP in men. It's a systematic review. So they took 662 research papers, and they whittled it down to 69 of these papers. So about 10% of the papers were used eventually for this particular review. And the findings are really quite conclusive. So it's fairly recent, the paper. Stretched back, they researched and amalgamated a whole host of papers over a period of time. I'm just going to summarise some of the summary of this particular paper. Again, you can find a link to it on my website, so do read through it. It's quite a long paper, so take some time and absorb it as well. I'm just going to highlight a few points. Patients, you might see some association here. Therapists, I just want you to be mindful that there are other things that are going on other than just physical presentations that are really, really key in understanding pelvic pain syndrome in men. So 25% of patients reported feeling helpless or hopeless. Makes sense? Especially when there's no real clear treatment path to follow, when there's no real clear indication as to whether this is ever going to end. And certainly when you're being told by urologists, GPs, for example, this is something you'll have to live with for the rest of your life, which I don't agree with personally, then it can often lead to a feeling of helplessness or hopelessness. Makes sense. Pain catastrophization predicted mental quality of life and pain intensity. So the more the patients catastrophized about their symptoms, the more they felt out of control, the more they worried and were concerned and catastrophized about the impact of what was happening in their life. And generally with catastrophization, we either project ourselves further forward into the future or we look back at how things used to be. How am I going to be at my upcoming wedding? How am I supposed to go for a job promotion? How am I supposed to go and get a partner? How am I supposed to have sex if I'm getting these symptoms? And that catastrophization often predicted the mental quality of life or lack of it and an increased pain intensity. Elevated levels of stress perception in chronic pelvic pain syndrome. So there was an elevated level of stress perception in chronic pelvic pain syndrome patients, and half of patients believed that stress increased pain. Now, I on Facebook a couple of days ago, I posted a question about what do you feel is some of the bigger factors that what are some of the bigger factors in terms of symptom escalation, and quite a few people put down stress. Now, having had chronic pelvic pain myself, having been where I was 12 years ago when I was going through this, I lost a testicle through a massive infection that ate away my testicle. So I have one testicle now. And at the time, I was incredibly angry, incredibly frustrated, incredibly stressed about what I felt to be poor medical care from what seemed at the time to be an uncaring urologist, someone who just I wanted to know whether I was still going to be fertile. As a young man in my mid-20s, wanted to know whether I was going to be able to father a family later in life. And he kind of poo-pooed me, pushed me off and just said, this isn't something to worry about now. In hindsight, I appreciate what he did, but at the time I certainly did not. Poor partner support led to greater feelings of pain and disability. Now, I find this really, really interesting. So this is a bit of a social interaction here as well, is that when patients don't feel supported by their partners, and I would kind of extend this out to perhaps family members and friends, but the issue here is that most patients don't tell their family members and friends what's going on, so therefore they often don't get the support. Vicious cycle. That poor partner support led to greater feelings of pain and disability. There was an association between severe pain and low satisfaction with relationships. And to be fair, when you've got pain down there, when you've got pain at the tip of your penis or an ejaculation, the last thing on your mind is actually wanting to engage in a relationship, wanting to actually even consider what might be happening in terms of a relationship. And remember what I said about my patient, the guy I introduced you to at the beginning, Tony. If he's getting pain on ejaculation, if he's been told there's an infection buried deep within his prostate, he's not going to want to have sex with his wife. In fact, conversely, he probably wants to avoid any kind of sexual contact at all. So the association between severe pain, low satisfaction with relationships, mediated via lower sexual function. And again, quite often patients experience a drop in libido, a change in maybe random erections, maybe morning erections, maybe nighttime erections. And again, I'm not surprised. Something that should be really, really pleasurable and something to look forward to now becomes a really painful experience. And therefore, it has such a knock-on effect onto our the way we perceive things as well. There is a correlation between post-ejaculatory pain and low quality of life. I'm having sex or masturbating, I ejaculate, I get my symptoms, what the hell's going on? This is really, really confusing. I don't know what to do with myself. I don't know how to manage this. Again, I'm going to come back to spousal support here. So spousal support and social interaction. So not just the support of your spouse or partner, but actually social interaction. Going and seeing mates, going and playing sports or hobbies or interacting with others, even at work, had an important role in the feeling of disability. So spousal support and social interaction play an important role in the feeling of disability. Some of the conclusions of the paper were that the low quality of life of these particular patients is an important issue that must be addressed by an interdisciplinary approach, not just focusing on the prostate, not just focusing on antibiotics to treat the prostate, not just focusing on overactive bladder, not just focusing on inflammation, but taking all of these things, putting them together. The influence of psychological and social aspects, as well as the psychic comorbidities in the course of male pelvic pain, seems to be underestimated and underrepresented in current research. Of course it does. They had to do a systematic analysis to gather all this information in the first place. So let me summarise that. So the psychological and social aspects of this particular set of presentation of symptoms is underrepresented and underestimated in current research. And one of the key things in order for patients to get back their quality of life is that to feel more normal, to have normal interactions, is that by increasing that patient's quality of life, they start to feel like they're able to do those normal things, that they're able to go and have sex with their partner, that they're able to go and have a drink with their mates or go and play sport and go and do those things that make them feel normal. Massively, massively important. So I wanted to they're the end of the research papers, that's the end of the academic stuff for now. I'm going to draw a little bit more upon it as we start to conclude this presentation today. Now, what is really, really interesting is that all of these aspects, the biological, the psychological and the sociological, they change from moment to moment, situation to situation, day to day. And how we respond in given situations and circumstances can have a really big knock-on effect as to whether the biological or the psychological or the sociological interactions. So I'm going to show you now an infographic. It's actually from nothing to do with pelvic pain, although it is to do with the biopsychosocial approach generally. This was a paper released earlier this year. I love this little graphic here because it suggests that given the circumstance and situation, that these things can change from moment to moment, situation to situation, day to day. And that also means that sometimes we might have greater symptoms, sometimes we might have less symptoms, sometimes we might be feeling like rubbish and like crap, other times we can't be asked to socialise, sometimes it's just all getting too much, and sometimes things are better, sometimes things are much, much worse. This is the nature of this particular condition. And when we start to appreciate this, when we start to manage each of these domains, then actually it starts to become a little bit more stable for the individual. Only addressing the biological, only addressing the psychological, only addressing the sociological aspects isn't enough to create stability and, in my opinion, successful rehabilitation. So why isn't this being addressed by the current medical practices? Well, I'm going to show you something now, and this isn't anything brand new. It's a bit of a busy slide here. I don't like busy slides, but if you can read it, or if you can't, I'm going to read it out to you. So UPOINT was something that was devised back in 2009, so quite a long time ago. If you're a patient and you've come across this and you've been assessed or triaged by this, I'm very pleased. If you're a therapist, you may well have come across some of the research to do with UPOINTs. So UPOINTs was a classification system that took into consideration the various aspects around a patient presenting with chronic pelvic pain syndrome and chronic prostatitis. It was originally UPOINT, and then in 2010 there were some amendments and suggestions made to consider the sexual domain. So U stands for urinary symptoms and is assessed by a post-void residual measured by ultrasound. So ultrasound before and after the bladder's been voided. P stands for psychosocial, and this is an assessment of clinical depression and catastrophization associated with male pelvic pain symptoms. O is for organ specific, and they might look at bladder voiding issues and prostate tenderness, although we now know prostate tenderness isn't particularly reflective of the presentation within a patient. I stands for infection, and they look at express prostatic secretions or prostate massage testing. N looks at the neurological system and is assessment of pain beyond the pelvis itself, and includes diagnosis of other pain syndromes that we often see with chronic pelvic pain syndrome. So they might be, for example, things like IBS, they might be headaches, they might be migraines, they might be psoriasis, they might be other ongoing sensations that happen within the body. T is for tight muscles and the palpation of abdominal and pelvic skeletal muscles, including muscle spasms and searching for trigger points. S is for sexual dysfunction, and this is the assessment of erectile and orgasmic dysfunction, including the impaired sexual desire, impaired sexual desire and intercourse satisfaction. So this came out, like I said, 8 years ago. And every single year, someone does a review of it, someone applies it to their patient group within the clinical setting, and guess what? They say it's really, really beneficial. In fact, earlier this year, a chap called a paper by Lee 2017, that's this year, demonstrates the obvious clinical benefits from the UPOINT-based therapy. Pain related to CPPS includes diversity factors that include the experience, that influence the experience, and the best treatment is considering different aspects of the condition. It's there. This isn't anything new. You can look up UPOINTs, type it into Google, other search engines also available. It's there. The information's there. It has been for ages. It's just not being applied at the moment in urology and with GPs as well. Really, really sad. Okay, I'm aware of the time at the moment, and I want to try and start to summarise some things as we move to a conclusion of this particular presentation. So, our reaction to pain can often determine how much of a pain experience we're going to get. So our reaction to pain can be based upon our situation, our circumstance as well. Let's take, for example, someone who walks into a packed lift and they have pelvic pain syndrome and they have increased urinary frequency and increased urinary urgency as one of their symptoms. So this is what I mean by how our symptoms can escalate and change given the circumstance and situation we find ourselves in. So patient with those particular set of symptoms walks into a busy lift and they travel to the 7th floor and they get out. No problems, no issues at all. Symptoms stay roughly the same. Now, same person gets in the same lift with the same group of people, travels to the same floor, but the lift breaks down. And this time they're stuck in a lift with a group of people that they may know or not know, and they're getting symptoms. And all of a sudden those symptoms start to escalate. And how we react to that set of change in sensation can really determine what happens to our pain experience. It can really, really ramp up very, very, very quickly. And the physical location of the symptoms makes it very difficult to deal with, but also our geographical setting that we find ourselves in. So most patients, when they're in the comfort of their own home, are very comfortable. They have relatively low-level symptoms, they're manageable, they're easy to deal with, it's a safe environment. As soon as that patient leaves the comfort of their own home, and this isn't every patient, by the way, as soon as the patient leaves the comfort of their own home or enters into a situation that could be deemed as being sensitizing, so for example, exams, going to university, an interview, getting on a packed tube, running late for your aeroplane at the airport. So all of these things are slightly stressful, and all of a sudden, if we're in a sensitized state, then stressful events can increase that sensitization. Surprise, surprise. I would argue that actually the physical location of this particular set of symptoms is also very problematic. That if you're sitting down and you stand up and you've got a stiff lower back, then you can probably demonstrate to the world you've got a stiff lower back. You can't stand up after having sat down with testicular pain and start rubbing your testicles. Well, I guess you could do. You might get some very bizarre responses, especially in a social situation. What about patients who can't sit down and they have to travel to and from work, but they choose the times they travel to and from work so as that they don't have to interact with the billion other people that travel to and from work at the same time. So they go before rush hour and after rush hour. But let's say on the way back home from work, patients had a really bad day, they're in a lot of pain and discomfort, and they're on the train, but they don't want to sit down. But the train's empty, and the ticket inspector comes past, and they ask the patient for their ticket to prove they're travelling okay, and then the guard says, "You okay? Do you want to take a seat?" What excuse does a person with pelvic pain have to say to that particular train guard in order to brush them off, to make them sound normal and not have to explain that they've got a real deep ache in their perineum, that actually urination's really uncomfortable today, and their sit bones are on fire? So our reaction to given circumstance and situation can often dictate our psychological, biological and sociological response. Our sociological setting can often change our psychological response and therefore have a physical reaction to that as well. So when we start to consider all of these different associations, we start to realise that this is an ever-changing arena, that things manifest themselves seemingly out of our control sometimes, but once we understand an awful lot of these other influencing factors, I personally believe that we can manage them an awful lot better and get greater symptom reduction and alleviation from that as well. So, to summarise and to give you a final consideration, male pelvic pain, chronic pelvic pain syndrome, chronic prostatitis is a challenging condition for those treating it and a challenging condition for those dealing with it. And I think using a biomedical approach, only focusing on one particular targeted area of the body, doesn't give credit to the patient. There is an individual in pain here. We have to remember that. Then the patient is more than just their set of presenting symptoms. There's a whole host of other things that amalgamate in this pain experience. And this includes factors within the biological domain, physical changes, factors within the psychological domain, so catastrophization, our thought processes that change, our worries and concerns, and actually what it means in society, whether that be our relationship with our partners, our friends, our work colleagues, or what does it mean in terms of our social situation and physical and hobby type situation as well. What does that mean for us as the patient starts to reduce or as we start to reduce our activity levels? How does that then change for us as well? How does that influence us? And I think by looking at some research that's out there at the moment, we realise that actually prostatic tenderness isn't exclusive for male pelvic pain patients, that patients who don't have pelvic pain get pelvic pain tenderness. That the amount of inflammation that's present within the prostate does not reflect the amount or the severity of symptoms. There are other factors that are at play here. That although pelvic floor tension is a contributing factor to some cases, not every single case, and that trigger points do not always relate to pelvic pain. So I can have patients with pelvic pain who have no trigger points. I have other patients who have no pelvic pain who have loads of trigger points that refer to the pelvis. No direct correlation. That when we address the psychological and the social factors in accordance with a systematic analysis, and we start to review those and implement them into practice, and the patient starts to view that there are other considerations, then I believe we get a greater chance of recovery and a greater understanding of this particular condition. So this has been the biopsychosocial approaches to the treatments of chronic pelvic pain syndrome and chronic prostatitis, part 1. Now, next week we're going to cover more applications to this particular model. So for therapists, this is going to include inroads into how to engage in further conversation with patients, how to draw information out from them that's relative to the biopsychosocial model. And for patients, I'm going to give you some practical ways of addressing this, some solutions that I can get you to use yourself, and just to start to get your creative juices flowing, to get you to think about considering above and beyond kind of where you are at the moment in terms of your presentation. So I want this week and next week to just get you thinking a little bit more about the condition, to just make you realise there are other things that are happening, other things that are going on. So a final consideration, and what I want you to make you aware of this is that when we're fit and healthy and we have no symptoms, and whether that's pelvic pain symptoms or any other kind of symptoms, is that we take our bodies for granted. We don't really realise how much we take them for granted. And it's not until we get symptoms, and not just pelvic pain related, but whether that be a cold or a broken finger or something far more impactful and sinister in our life, that then we start to take stock of actually how much that impacts upon our life, and how much we use our body without thought and without preemption. And we often forget what it means to be healthy and fit and capable. But as soon as we have any illness, we start to realise how much it impacts on our life, and how much we use that body part, and how much it now starts to limit us, and how much it starts to permeate not only through our actions, our interactions with others, our thoughts and our behaviours, to name a few. And chronic pelvic pain syndrome, chronic prostatitis is no different from that. And as soon as we start to realise that there are so many other factors that present in this particular set of symptoms, I think the greater chances of improved recovery, of symptom awareness, of patient and therapist alliance, I think that's a really, really good and positive thing. So I want to thank you for joining me today. I hope you found it beneficial. I hope you found it insightful. I hope you found it inquisitive into an area that often isn't inquired into in a great deal. Like I said, I will post underneath this Facebook Live presentation a link to my blog post where you can find other details and other papers from today. And I look forward to seeing you again next Thursday. That's Thursday the 14th, 11 a.m. for the biopsychosocial applications to chronic pelvic pain syndrome and chronic prostatitis part 2. Thanks very much.